On PM Express tonight, the AIDS war, examining the alarming new figures that we heard about when the world marked International Day for Awareness as far as that particular infection is concerned. And we're beginning to appreciate some real tragic figures. This one, for example, 170,000 adults with the virus are not on treatment, which itself is devastating already. You would think that after all the years of a lot of investment in this particular fight against the disease, this shouldn't be a story that we should be telling 2019, but sadly it is. 170,000 adults living with it right now. They are not on treatment. Now, the number accounts for more than, and this is a shocking reality, accounts for more than half, that is more than 50% of the number of people living with HIV in the country. That is a big problem. I mean, to begin to appreciate this. Now, Ghana is not likely, for what we are hearing, to achieve the 90 target aimed at ending the spread of the virus by 2020. That's a global target, by the way, that has been set, by UNAIDS. Now, the target has been issued by UNAIDS. It's a treatment target to help end the AIDS epidemic. Yes, we never thought we'd get to a point where there will be even a plan and a roadmap towards ending the epidemic, but there is, and Ghana is falling short of that particular target. Now, HIV antiretroviral medicines not only prevent the disease progression, but also suppresses the viral load to undetectable levels, and that is why the treatment is so important. You can be taking antiretrovirals, get to a point you will test for HIV/AIDS, and you will not even have a positive, outcome, because although you have it, you have it, but because it has a way of just suppressing it completely from your system. Now, Ghana's efforts in achieving the target I told you about, the 2020 target, is being stalled due to huge number of victims living without the antiretroviral drugs. We're going to try and understand why this is. This is a case that people can't afford it. The drugs aren't available. What is it that makes this a problem for those who are living with the disease? Also, people are making personal choices not to use the antiretroviral. So we're going to dig into that, examine those figures a bit closely. The question to ask tonight is, we need to look closely at these numbers. Why are we getting them? And what can be done to reverse that trend? You want to stay with me here on PM Express, one of those conversations that you rarely get to hear about, but it's absolutely crucial to your health. Stay with us on PM Express. My guest in the studio this evening is the Acting Director General of the Ghana AIDS Commission, Chairman Etiahene. Mr. Etiahene, thank you for your time here on PM Express. It's good to have you. We rarely talk about HIV/AIDS. Yeah. Is it that we're winning the war? We've won the war, and so it's no longer an issue. Do you have the same sentiment, though, that it's sort of gone off the radar a bit?
Yeah. First of all, thanks for having me. Yes, indeed. Many people ask me the same question, but clearly it's a matter of complacency on the part of many of us as a people, as a society. And so we are happy that multimedia is picking it up. Other media houses are also taking interest to discuss the issue about HIV. And so we need to look at the issues now, because as a country we've come a long way. Since 2010, we've been able to maintain low prevalence, below 2%.
Okay, well, what does that mean, though, when the 2% low prevalence? In real...
What that means is the adult population of Ghana has less than 2%, being adult population of Ghana, we have less than 2% being HIV positive or living with HIV. And that, in terms of numbers, currently, as at the end of 2018, was 334,700, and so I usually round it up to about 335,000
people living with HIV/AIDS.
People living
adults
with
living
HIV.
in the
Yes.
country. But that's a very tiny little number. No wonder we shouldn't be worried about this.
It's not
We
tiny.
are 30 million people. If only 300 million, 300,000 of them have it. It's no big deal.
It is a big deal.
Life is rosy.
It is a big deal because of the nature of the epidemic. HIV epidemic is quite unique. It's only come close to Ebola because when the virus enters the body, it replicates itself or multiply itself, you know, at a very rapid rate, and they multiply in billions, you know. So if there is no intervention, the person after infection can, you know, survive between 10 to 15 years.
HIV?
Yes. And
without intervention?
Yes, without intervention.
Oh, so you're saying that if I get infected today, without taking any ARVs or anything, I can live up to 15 years?
Yes, depending on your immune system. Okay, so some may not even last, that's the average, but some may not even last 5 years. Others may go, you know, to 15 years or more. But obviously by 15 years, the immunity would have been really broken down, and the person would succumb to AIDS. And that is the last stage of the infection or the disease. And so at that point, if the person doesn't seek treatment, then he's on his way
to the grave.
To the grave.
I mean, but you know why 300,000 people infected? People will say, well, that possibly is what, one in how many people in Ghana? Right? What's the ratio?
For male, female?
Yeah, I mean, so that's what you look for. See, I mean.
Okay, so HIV, as it is in many countries, carry female, you know, face or woman's face.
Why do you say
that? Because women are disproportionately affected by HIV. So in Ghana, we have about 65% of persons living with HIV being women. I
mean, why is that? Because what, women's genetical, biological makeup make them more vulnerable, susceptible to the virus? Exactly,
because the genital of a female is more of a receptacle. It has a wider surface, and of course the mucous membrane can be fragile, and so if a woman sleeps with a man who has HIV, and if there are any abrasions on the vaginal wall, then obviously she stands a very high risk of contracting HIV.
So it's possible that an infected woman may have sexual intercourse with a non-infected man, an HIV negative man, and the man will not get it?
Yes, it is possible, especially if the man is circumcised. Circumcision is protective factor, and so it is highly possible for the man not to be infected. It is much easier for a woman to get infected than man.
So let's look at some of the big issues that have come up this week. For you, what are they? What are the big issues that worries you, gives you sleepless nights in your job?
Yes. One of the issues that we are focusing on is the fact that it is possible to end AIDS and achieve epidemic control in Ghana.
You say eliminate?
Yes.
HIV/AIDS?
Yes.
It's, to even hear
Yes.
you use the words alone is just hard to believe that you're actually telling me that you are confident that a time will come when there'll be 0 cases in Ghana.
Well, globally, the global commitment is to end AIDS by the year 2030.
How are you doing this? That all the people who have it will die, so that we start afresh, or or that you kill the people?
No, it's rather the opposite. We will keep all the people who live with HIV alive, healthy, and productive by placing them on antiretroviral treatment. Now, the antiretroviral medicine suppresses the virus in the body, such that it's able to bring the virus to a very low level, to, let's say, undetectable level.
Yeah.
And at that point, that person is highly unlikely to transmit the virus to his or her partner. And so if we have all the about 335,000 people currently living with HIV in Ghana on antiretroviral medicine, within 6 to 12 months, if they adhere to treatment, they will become virally suppressed.
That's how short it takes to suppress
the virus.
Yes,
that's how short it takes. They will become virally suppressed. But of course, the medicine is for life. Once you start, you continue until you die or we find a cure.
It's like a BP medication.
Exactly. Because now HIV is a chronic disease, just like BP or diabetes. And so once they start, they continue till the end of their lives, or when we find the scientific community finds cure. And so there is high possibility for us as a country to achieve this, eliminate HIV in the country within the shortest possible time. In fact, we will want to see the end of this epidemic much earlier than 2030. Much earlier than 2030, and it is possible. And so, as a people, we need to work together to achieve this. First, we have to diagnose and identify those who live with HIV, all of them. Now we know we have 185,000 of them.
How do you know this? I keep on hearing the figure, but how do you know this? Because people's medical records are private, so how do you know that they have that?
Yes, they are private, but they must be used to improve performance of the program. Okay, so we use the data. Now, it is private and confidential, which means I can't tell you that, James, who works for you, do you know he has HIV? And in fact, we have 5 people in multimedia who have HIV, and he's one of them. When I do that, that is unethical. But you can use the data, to analyze and plan, take decisions, based on the data.
Let me break this down a bit more. So if I go to any health center to check my status, and it's checked, and touch wood, God forbid, I'm positive, how do you get that statistic?
Well, they are supposed to report.
Okay.
The health facilities report periodically. And so they, for example, report to the Ghana Health Service on monthly basis. We get the report on quarterly basis. Okay, so
So you see why I will always wonder this 300,000 number you give could be heavily understated, because all these factors, hospitals, clinics, whatever, may not be reporting as they should. You know.
Yes. So that number is not based on program data that you are referring to.
Okay.
Is based on projections.
Okay.
Now, and we use the program data as part of it. Population-based surveys results like DHS is part of it. Quite a number of data sets are all put together. Some on fertility, some on the Sentinel surveillance report is there. DHS HIV prevalence data is in there. So every data on HIV and related indicators are all put together, and we run the program and generate the estimates and projections. And it's the same that is done by UN, you know, and actually the software we are using is from the UN.
Oh, so we have a software for the estimation.
Yes, and we work, you know, closely with the UN to estimate or project the Ghana's situation.
Why is that number important? Why is it so crucial that we know how many?
Yes, for planning.
And this is still still talking about this, your plan to eliminate it. Once you know this is the number you have,
yes,
then how does it help you achieve the target?
Good. So our target for us to end AIDS by 2030, we have to achieve the 1990 targets. And the 1990 targets, as you know, is part of the SDGs, that's the Sustainable Development Goals. And it's a global commitment, and every country is supposed to achieve it. However, the UN reported recently that not many countries can achieve this target by the end of 2020.
Ghana is one of those who
can. Yeah, Ghana is one of those countries. Now, the first 90 says that by the end of 2020, 90% of people who live with HIV must know their status, which means we have to test them. We have to provide testing for them to know that they are positive or negative. And once they test positive, the second 90 says that we should put about 90% of those who know their HIV status on antiretroviral treatment. And the third 90 says that those on PLHIV on antiretroviral treatment, we should see 90% of them becoming virally suppressed by the end of 2020. And that is our focus to achieve these targets. Although we are missing the targets by the end of 2020, we are going to ensure that in 2020 we intensify our efforts to enroll more and more people on antiretroviral treatment and retain them on treatment.
So there are countries in the world where next year they would eliminate HIV/AIDS.
Yes, we have countries who have achieved the 1990 targets
already.
Yes, and some are on track to achieving
Can you tell me that country? I want to go there and have fun.
Okay, so we have Zimbabwe, for example.
In Africa?
Oh, yes.
Zimbabwe?
Yes, Zimbabwe.
They have achieved it.
Rwanda.
Is it the same Zimbabwe that is in crisis economically?
Yes, yes.
How did they manage that?
Okay, so there are 5 factors that characterize these countries that are on track to achieving the 1990 targets. 1 is high political commitment. 2 is sustained investment in HIV. 3 is more of social mobilization, where various communities are involved. and we have strong community level HIV interventions. And these countries share these characteristics. And we have to also bring the same to Ghana.
We have none of the things you mentioned. Political will, investment, social mobilization, zero.
No, it's not zero.
Really?
Yes.
Where is the political?
We have very high political commitment to HIV program in this country.
In 2019?
Yes. It has always been from the beginning.
What makes you say that? What's the evidence?
Yes, because the president himself is at the helm of affairs when it comes to HIV. He is the chairman of the Ghana AIDS Commission.
But that's just an architecture.
No, it's an architecture.
But of the way the AIDS Commission is set up.
I can tell you from the beginning till now, the roles the successive government or heads of state have played.
But the real measure will be, for example,
yes.
Do you get all your funding? Do you get it on time?
Yes, we may not get all the funding from government.
Yeah, but we have funding. That's a major indicator.
Yes, we have funding from donors. And
but that has dried up over the years.
It's drying up, true. It's drying up. But it has helped to sustain. But in fact, when we started, it was not just donors. Government took the initiative to ensure that there is adequate funding, even to the extent of borrowing from the World Bank on 2 occasions for 2 medium-term plans to be implemented.
When is this, 2017?
2002, okay. we had a grant of 25 million from the World Bank. Of course, then other donors came in, and that was about the time Global Fund also came in. And then
that is a long time ago.
That's a long time ago. Then 5 years after, we had same amount from the World Bank, you know. So,
but I don't have anything close to that, at least recently.
Not Ghana's commission, but as a country, we still have money from the Global Fund and from the US
HIV
government.
AIDS interventions.
Exactly. For HIV, in fact, the medicines all of it used to be provided by the Global Fund and PEPFAR, that is the US government. But now, as funding is being scaled back by donors, government is filling in.
With taxpayers' money?
Yes, sure. And buying HIV commodities, antiretroviral medicines, rapid diagnostic test kits, condoms, for example, reagents for lab activities. The government is providing.
I used to get boxes of free condoms back in the day.
Yes.
I mean, that's 10, 12, 8 years ago. I used to get boxes of free condoms quite regularly here. They bring it here to share. Even that is no longer existent.
That is one thing that's
so basic.
Yes,
I guess it tells you that we've lost it.
That's basic, and you are right. And it is something that we are actually going to do, and you see more of it, even beyond your expectation. We want to saturate this country with condoms, using condom vending machines, and also making it available, you know, at various places. And we have an agreement with a private organization which is going to support us do this, you know. So
that the vending machines work like how? ATMs?
Exactly. Exactly. They are vending machines that not only dispense condoms, but also candies, you know, even paracetamol, over-the-counter, you know, kind of drugs that people may frequently use.
What's the timeline? When do you want to roll this out?
Oh, by early next year, we should see this.
Yes. Yeah, you're encouraging promiscuity.
Yeah. No, no.
you're going to have vending machines with lollipops.
Yes.
In it. That's enticing people to be promiscuous.
No. You see, they are doing it already. And if they don't protect themselves, they get infected. And for most of the people who are infected in Ghana, they decide to do something about it only when they are in bad state. Okay? So you want to ensure that you protect them, especially as more and more young people are getting infected. So you save them before you bring in other interventions that would change, their lifestyle. So you give them the condoms so that they can protect themselves. How
are you, this is a very religious country.
Yeah.
How do you deal with that? Because that could be a problem. Because the religious, the very Christian, staunch Christian, believers say, no condom. Abstinence is the thing. There's an age-old debate, but that debate hasn't stopped because we still remain a largely Christian, in terms of the population. More of us are Christian than anything else. That definitely is going to be a problem now that you intend to saturate the country with condoms and condom vending machines.
Yes. So what that means is that we are looking at the reality of the situation. The young people of today do not think the way we used to think a decade ago. They are different, and their preferences are different. In spite of the fact that they may look or behave like highly religious people, Kofi Kinata has demonstrated clearly what it all means. And so it is important that we save that generation. Because if you look at the data, the ages between 15 and 35 are the most affected.
By HIV?
Yes, by HIV.
They are the most vulnerable, or they are if you look at the 300,000 you mentioned, they're the most with the virus?
They are in the majority.
Okay.
That's what it means.
15 and 35.
15 and 35. They are in the majority. And so, and this age group is the productive age group.
True.
It's also the reproductive age group.
True.
And so if we do not do anything and allow them to get infected, then we have ourselves to blame as a country. And so we are using public health approach to ensure that people who are at risk are protected, and those who are infected are also given the necessary help or treatment, I should put it that way, so that they can live longer and be productive.
Let's talk about the treatment, because one of the biggest concerns there is now is that the figure you gave us this week, 170,000 people living with it, are not on treatment. That is alarming.
Yeah.
Why aren't they on treatment?
There are a couple or so reasons. One is the fact that many people think that going to the health facilities would expose them.
To?
It will make people will get to know that they have HIV.
Okay, so there's a stigma. They're afraid of the stigma.
So the stigma. And some also are seeking alternative treatment or help because you hear many pastors or prophets, claiming to cure people of AIDS. And it's the same with herbalists. And that is really making people living with HIV move from place to place seeking healing, because they have been told that antiretroviral will not heal you. It won't cure you. And so they want a cure, not treatment. But the truth of the matter is that For most of them who do healing shopping end up coming back to the hospital for remedy, for treatment.
And sometimes they come late.
And sometimes they come late, and the doctors can do their best. Some are usually, rescued. They are usually they get treatment and they get better. A few of them die off, and that is not too good. It is antiretroviral treatment is best when you start early, because if you start early, then you are not going to have this disease progression, so you maintain your health, all through, and there won't be a situation where you can skip work because of ill health. No. And so it is better for people who think they are healthy, look healthy, to test for HIV. And immediately, if they test positive, giving antiretroviral medicines. Now, HIV is being handled like malaria. When you have malaria, you go to hospital, they check your blood whether there are parasites in there. If there are, then they give you malaria treatment. In the same way, when one is tested positive for HIV, immediately is given treatment.
You mentioned that one of the reasons why many of these infected are not on treatment is because of they simply don't trust. But you also hear a lot of people saying they have a cure, but that's one of the reasons. But it couldn't be the only reason, because
no, not the only reason. The other reason is, which I started with, stigma, and there are two types of stigma. We have stigma, which is the general one we all know, display of unaccepting attitudes towards persons living with HIV. Yeah. And that one is quite general, is quite pervasive in our society. Yeah. And so it kind of drives people living with HIV underground, and they wouldn't want to do anything that will make others know that they have HIV. And not seeking treatment is one way of, hiding one's HIV serostatus from their family or community or church, whatever that might be. There is also internalized stigma, or what we call self-stigma, which relates to people who live with HIV, who feel that because of their infection, they are different, or they feel inferior, or they don't have the confidence to engage and interact, and so they keep to themselves. And therefore, that prevents them from also accessing HIV services. And that is also quite pervasive among the persons living with HIV. We also have a third group, whom I call the angry people. They think that they've been treated unfairly by being infected with HIV. And so if they usually say, if someone gave it to me, then someone else must also have it from me. And so it's more of a vengeance. And they spread it. And in order that people will not know that they have HIV, they have to make sure they do everything they can to keep their status.
Including not go on treatment.
Exactly. Including not going on treatment. So that is quite worrying.
But is the medication available, accessible, and affordable?
First, it is free.
Okay.
Antiretroviral medicines are free in all health facilities where they are administered.
Every health facility?
Every health facility where they are administered. We have about 500 health facilities where we have antiretroviral treatment centers. Besides these, we have about more than 3,000 PMTCT facilities.
What's that?
Also. Oh, sorry, prevention of mother-to-child transmission. Okay. So these are the ANC antenatal care centers or clinics where pregnant women, you know, go for antenatal services. Yes, in some of them you can have it, because we don't want mothers or pregnant women who need the medicines to move from ANC and go to ART center, which may be outside her residence, you know, maybe far distant away from where she lives. And so we are trying to bring treatment to the doorsteps of the people who need it.
But in the past, we've heard about shortage of the antiretrovirals.
But no more now. But even when we had shortage of the imported ones, we usually will fall on local producers, local manufacturers.
Antiretrovirals are being manufactured locally?
Yes, over a long time now. For a long time now.
With the same efficacy?
Sure. Sure. And that has always helped. But now we are not facing that kind of problem, because the supply chain arrangements ensure that we avoid stockouts.
But why must I go to a center to get a medicine? Isn't it like a tablet?
Yes.
So why can't I just go to the pharmacy and get it just like my BP drug?
Yes, that's true. HIV drugs are program drugs.
What does that mean?
That is the decision of government, that it can only be administered in health facilities.
Why?
Because of the fact that first, the policy is to make it easily accessible and affordable. That is why government has decided to give it out for free. Okay, so that's number one. And how do you ensure that it's given out for free? If it is in the pharmacies, it's definitely not going to be free.
Okay, but there are people who have money, they want to buy it.
Yes, so if you want to buy, that is fine.
Where do I get it?
But this one, you get it only from hospitals.
Okay, so the free one from the hospital?
Yes.
But if I have money, I don't want to go to the hospital?
It's actually illegal for pharmacists to be administering antiretroviral medicines.
Is it in the law?
It's wrong.
It's not illegal, it's wrong. They are two different things.
No, it's against the government policy.
So it's a policy?
Yes, it's against government policy.
But why? I don't understand that.
You see,
it's just a drug that you put and drink water on.
It doesn't work like that, you know. Everybody, you see, it's not just giving the drugs. It's also making sure that the patient tolerates the drug. It's also making sure that the patient is monitored on a regular basis to ensure that the vital organs are all functioning normally. And so it is bad for anybody to access the medicine without, you know, clinicians monitoring.
What, is a drug that bad with its side effects?
Every drug has side effects. Even water has side effects.
True.
Yes. So as you take, if you are on BP, your doctor will want to make sure that as you continue to take the medicine is working for you and it's not causing damage to your body in any way. So it's not only HIV. Every other treatment, doctors make sure they keep close eye on you so that...
Yeah, but I don't have to go to the hospital to take that medicine.
Yes, so what I know that is a border for many people. Yeah, and we are trying to
prevent many people from going to
exactly. So we are trying, the Ghana Health Service and other service providers. The policy is that we give, for stable patients, we give between 3 months to 6 months drug allocation so that they don't have to go every month to collect the medicines. And we are also making arrangement to move it from, let's say, the hospitals to even the CHIPS compound level, so that it gets closer to the users. Okay. We are even hoping that soon we'll be able to use community structures to distribute the medicines, because we have, and that is even happening. We have people who live with HIV who have been trained and supporting the health facilities as a model of hope. They are the ones who counsel and support the newly diagnosed PLHIV, that's persons living with HIV. And for some of them, they are able to take the drugs and send to the clients, PLHIV in the community. So these are things that we are trying to strengthen, expand, so that it becomes easier for people to access the medicine. We are also, the Ghana Health Service, NACP, is working very hard to ensure that health facilities make flexible arrangements for people who they may not come to clinic during clinic hours. Maybe they can come outside clinic hours. Like now, if I want to go and take my medicine, there should be somebody there who will make it available.
So what you're saying, this is something you take it every day?
Yes, every day.
So every day I have to go to a health center?
No. They give you, when you start, they will give you 1 month allocation. And then
so you only
with
return to the
So when you become virally suppressed and your condition is stable, then the doctor knows that he doesn't have to see you every month. So he give you maybe 3 months drugs for 3 months, or drugs for 6 months.
There are people
so
who reject the drug, you said. There are people who reject, as in their body simply reject the drug.
Not reject, but let's say they are not, they can't tolerate it. And
what
if they can't,
they get
what that means is that, you know, people react to drugs. So if you don't want, if no physician will want adverse event, you know, arising from drug administration. That's why they need to keep an eye on the patient. So if it's not tolerable, right? The physician will change that medicine and give the patient one that he can tolerate.
So there are different types of, depending on your reception to it.
Exactly, but generally what is administered in the country is okay for everybody.
Is this policy about always going to is this the same thing in the US and other places?
Yes.
Okay, so in the US you still have to go to the hospital to go and get it. You can't buy it off the shelf.
No, I don't know what pertains in US, but
is this in global, international
most African countries
have that system?
Yes.
Okay, I want to take a quick break. Yes, go on.
Yes, because if you don't do it that way, you are rather going to create more problems for the patients.
Okay. Well, I want to take a quick break. When we return, we'll talk about the gay and lesbian community, because that is a big part of any HIV conversation, and how the AIDS Commission is dealing with that part of it, as of course we have a conversation towards achieving the target of eliminating it in this country. Stay with us. And you're still live on PM Express, and my guest is the acting boss of the AIDS Commission. Very fascinating conversation. There's something quickly I want to touch on before I go to the controversial subject of how you're dealing with those with you know, the gay community, which is, I mean, back to the administration of the antiretrovirals. Many people will not go to the hospitals for it, because if I go to the hospital for it and I'm queuing for the HIV/AIDS, everybody else in the hospital knows I am positive. So because of that, I will not go to the hospital and show myself that I'm positive. I'll sit at home. That's because I'm afraid of the stigma.
Right. But what we are trying to do is to remove the stigma associated with the HIV clinics. So we now we have a new stream of service delivery in some of the hospitals. I've been to Discoff, to Sunyani Regional Hospital. They have integrated approach where all chronic diseases have one clinic.
Okay.
So those chronic diseases include HIV. So you go in there, you don't know who has what.
Okay.
And that seems to be the new direction that we should go as a country. So we are having conversation around that. We also have the Ghana Health Service led by the National AIDS Control Program is also working out an arrangement where there will be flexible hours for people who don't have the time or would rather want to, just go in there, pick their medicines and go away.
Yeah.
So, and there is even VIP times, clinic times. They go in there on appointment and nobody knows anything about it. So that flexible arrangement exists.
Yeah.
But to kill stigma takes only courage on the part of the persons living with HIV to really declare their status and live normal lives. Until that happens, stigma will continue. Last year, we had one British parliamentarian who stood on the floor of Parliament and declared his status and said, I am HIV positive. I have been on antiretroviral treatment for so and so years, and this is what treatment has done for me. I am healthy, and I am productive. I don't have any problems, and so the stigma must go away.
Maybe we can get a politician to do it, and then
yes, and it's not only politicians.
Everybody else.
We have celebrities who live with HIV.
Yeah.
We have women, men and women in the media who have HIV. We have lawyers, doctors, chiefs, priests.
They should lead the way.
They should lead the way. Let's encourage, because HIV is now a chronic disease, and it's just like any other chronic disease. So
just to wrap up, you just spare a few seconds to talk about how you're targeting the gay community, because that, if you read the literature, it's always a very dicey area because they are also, a higher risk. Okay. What's the AIDS Commission's approach there?
Well, first of all, as a people, we need to accept that there are men who are engaged in same-sex relationships in Ghana. We have more than 50,000 people who we call men who have sex with men in the country, spread all over the country. Every region you can find them. Our work is public health. We have to support the at-risk or the infected in order to protect the general population. And because the men who have sex with men are one of the now we don't say high-risk groups, but one of the disproportionate affected groups so far as HIV is concerned.
Because of time, the intervention is what exactly?
And so the intervention since 2004, we have had sustained prevention, treatment, and care services for these groups all over the country, and they are doing very well. They are doing very well, and they come from our own communities, our own families. You may not know, but they are everywhere, in schools, everywhere, workplaces. And so they are human beings like us. So our duty is we cannot discriminate in our services. And we also know that if we protect them, we are actually protecting
ourselves.
The
general public.
The general public.
I mean, I'm grateful that you joined me. Great education on the subject of HIV/AIDS. Acting Director General of the Ghana AIDS Commission there, Mr. Chairman, well, I've learned a lot about this. We'll return to this conversation sometime again. Enjoy the rest of your evening.